Well, thank you everyone for being here. Good evening and welcome to Myositis and COVID, a webinar for Myositis Awareness Month that's sponsored by Myositis Support and Understanding, or MSU as we call it. We are a patient-centered, all-volunteer 501c3 nonprofit organization. MSU serves the myositis community, patients, care partners, and family members living with the myositis cluster of conditions, also known as idiopathic inflammatory myopathies. Hopefully I didn't embarrass myself there in front of my doctor. I'm Emily Fillmore. I'm one of the founding directors of MSU, and I'm currently a board advisor and volunteer. I'm also the author of The Marvelous Transformation, Living Well with Autoimmune Disease. I've had dermatomyositis for over 26 years. There's some question of whether I have juvenile form because I was sick before the kind of acute onset. But you know, it's hard to know because of the time that I actually showed the acute symptoms. I am so proud to be part of MSU because we provide amazing educational and support programs that weren't available to me for very many years until I met Jerry Williams, our founder and president. We also offer a patient financial assistance program to help myositis patients with emergency household expenses, medical bills, medical travel to see specialists, and mobility and medical assistive devices. Finally, we advocate for myositis patients in the medical and research communities and so much more. You can find out all about our programs at understandingmyositis.org. Pretty easy if you know how to spell myositis. Quickly, I want to point out that with me tonight, we also have the following representatives from MSU. Jerry Williams, again, he's our founder and president. Lynn Wilson, our vice president. And Manuel Labinas, I hope I didn't say your name wrong, Manuel. I tried really hard to practice that. Patient-centered research advisor. And this evening, I have the great pleasure of welcoming my neurologist and someone who I adore, by the way, Dr. Mamatha Pasnoor. Dr. Pasnoor has a long list of credentials. Most relevant to our talk tonight, though, is that she did her residency in neurology and a fellowship in clinical neurophysiology with a focus on neuromuscular diseases at the University of Kansas Medical Center. After completing her fellowship, she joined KU's faculty, where she treats me, on a multidisciplinary patient-focused team. She and my rheumatologist work very closely together to help me get the right program. Dr. Pasnoor is certified by the American Board of Psychiatry and Neurology, American Board of Neuromuscular Medicine, and American Board of Clinical Neurophysiology. Those are a lot of hard words for me, sorry. She also serves as a co-director of the University of Kansas Neuropathy Center, along with Dr. Dimachkie. He's the program director of the Neurology Residency Program. I messed that up. Along with Dr. Dimachkie, program director for Neurology Residency Program and associate program director for Neurophysiology and Neuromuscular Medicine. Dr. Pasnoor's.
1 second, Emily. And for those of you that are here that might remember, we did a talk with Dr. Dimachkie about the arimoclomol clinical trial, a sit-down interview style that was really popular. So Dr. Pasnoor is their colleagues, co-directors of this center. So I think that's just so amazing. So thank you for pointing that out, and back to you.
Yes. And I've actually met with Dr. Dimachkie before. He's wonderful too. Dr. Pasnoor's practice focuses on neuromuscular diseases and general neurology. She has published in many areas, including the myopathies, and is actively involved in research. And she definitely provides patient-centered, compassionate care in neurology and neuromuscular patients. If you know me, you know I'm pretty picky about who I have for doctors. So Dr. Pasnoor welcomes questions. So please locate the Q&A icon on your Zoom toolbar and enter your questions there. If you put them in the chat section, there's a chance that they'll get overlooked. So please join me in welcoming my doctor, Dr. Pasnoor.
Well, thank you. Thank you, Emily, for that wonderful introduction. And I'd like to thank all the organizers of the MSU. And I think you guys are doing a great job at providing all the information to the patients. And I think it's an excellent opportunity for me to be here and talk to the group. And feel free to interrupt if you want, or, I'll probably get the questions at the end, but, we'll just jump right into it. And this is, I think, is a very important topic, COVID. And I get a lot of questions in the clinic, and I have a lot of patients that I try to convince that we need to take the vaccination, or, we'll talk a little more about it. But these are my disclosures, but nothing relevant today to this talk. So this is, as we are talking about myositis, or the more commonly, as we know, as idiopathic inflammatory myopathies. Again, there are four major main ones, but other associated ones we are looking at those: polymyositis, dermatomyositis, inclusion body myositis, and necrotizing myopathy is what most of you are familiar with. And then now, more recently, we are hearing more of the myositis with overlap with other autoimmune conditions, and malignancy associated myositis, and juvenile myositis, like Emily was mentioning earlier. Again, it can be dermatomyositis or polymyositis. And that's the general classification of myositis. And then, as we all know, there is a pathological classification. Basically, we are looking at, what the muscle looks like. And based on that, the dermatomyositis has a specific kind of pathology. When we do the biopsy, you're looking at, there's inflammatory cells. Again, in this, there's different kinds of inflammatory cells. We'll be talking about a little bit on that, because those are all important for your treatment. And also, as we talk about COVID and, what happens there. So with dermatomyositis, you see like perivascular atrophy. That's very classic for dermatomyositis, where there is atrophy of the muscle fibers. What you're looking here is muscle fibers, and all these blue dots here, you're seeing the inflammatory cells. And again, this is the dermatomyositis. The IBM, the inclusion body myositis, is another rare entity that it's seen, where you see like the vacuoles in the, like a holes, basically, in the muscle fibers. There you see those vacuoles. And then in the polymyositis, what you're looking for is an invasion of the muscle fiber by the inflammatory cells. And in necrotizing myopathy, what you're seeing is there's all damage of the muscle fibers, and there's inflammatory cells invade the damaged muscle fibers, unlike the polymyositis, where the muscle fiber is normal and you see the inflammatory cells and entering. So it's all, basically the inflammation happens, and that's what causes the myositis or muscle inflammation. And there are other classification, again, based on what all antibodies that you look at. Again, we think there's a lot of other antibodies that are seen in these. Some are myositis specific, some are myositis associated antibodies. Again, you see certain like HMG-CoA reductase antibodies, and like statin, that is necrotizing myopathy. Someone who's taking statins, you see necrotizing myopathy, and you see that in that. And these are all important to know, again, for our, COVID also, again, we'll talk about it, why we really need to know about the antibodies. These are, like I said, different kinds of antibodies there, and there is overlap with the different syndromes with the myositis. Like dermatomyositis has certain antibodies, MI2, TIF, MJ, whereas polymyositis and necrotizing necrotizing myopathy, you see SRP, you see, again, there is some overlap between Jo1 and PL7 and PL12. And then we have, these are some of the antibodies that, so the pathogenic mechanisms, we think there's different mechanisms that causes these this inflammation in the muscle. So what leads to inflammation is what is important for us to know is, again, is it genetic? There is genetic factors that have been discovered. There's been like non-inflammatory mechanisms, the myokines cause it. There's some innate immunity, like it could be what your immunity in your body is, what is causing the inflammation, and the mechanism in IBM is totally different. Again, this is a complicated picture of what I'm just going to simplify it and say the chemicals, the environmental risk factors, like maybe the chemicals, the smoking, the drugs, the implants, the viruses, all of these can trigger an autoimmune process in your body. So you should remember this. Viruses too, again, COVID-19 is a virus. So can it cause an inflammation of the muscles? That's another thing to keep in mind. So these environmental factors, along with your genetic constitution of your body, like your certain types of HLA, certain type of, genetic constitutions, these, along with these, trigger like an autoimmune process in the muscle fibers. Again, it has to be the right combination. And basically what happens is they triggers the T cells, B cells, and other like stress causes hypoxia. There's a release of the substances that damage your muscle fibers and cause these various conditions. That's the polymyositis, dermatomyositis, inclusion body myositis, and necrotizing myopathy. Again, this is just a complicated picture of the same thing, how it triggers, like some antigen coming into your body triggers an immune process and releases and causes antibodies that may have some innate, like some similarity to your muscle fibers and cause damage to the muscle fibers. So that's what we think is different. Or it can be like triggering a T cell, like causing direct cytotoxicity on of the muscle fibers. So there is different mechanisms that have been postulated. Again, I don't think anyone knows for sure which is the right mechanism, and it's probably a combination of these mechanisms that causes the damage in the muscle fibers. So these all are what leads to that. So coming to COVID-19 and myositis. So what is the risk of COVID-19 infection? People have always asked the question, I have myositis, do I have an increased risk of infection with myositis? And the answer is myositis itself is not a risk for COVID infection. But if you're on an immune suppressing medication, so if you're on some medication that suppresses your immunity, there's definitely you're at an increased risk of infection. Again, not all medications cause that effect, but some of the medications that you prescribe for your immune process, for your myositis, might cause suppression of the immunity and lead to infection. The other thing is, COVID-19 infection, and just if you didn't have a muscle disease, for example, and you had a COVID-19 infection, can you have a muscle disease? Can that trigger a myositis? Can that trigger an infection? So that's something which I'll be talking a little bit in the next slide. And the other thing, the next question, which we all have in mind, is like COVID-19 and vaccination in immunosuppressed patients and myositis patients. Is that something we should do, or when should we do? And, these kind of questions that we have in our mind. And we'll talk a little bit about each of these along the way. So COVID-19 and muscle symptoms. So what kind of muscle symptoms are we seeing in COVID-19 infection? So someone who has COVID-19, we have seen that myalgias are very common to see. What does myalgias mean? It's mainly muscle aches, basically. And this has been a high prevalence in patients. And it's not just COVID, but even if you look at any viral infection, any infections, the muscle aches are pretty common to see. So myalgias have been prevalent in this. They're about 11 to 50% of the patients have that. And in one study from Wuhan, very earlier on, they studied this. They looked at 138 patients, and out of which they said 34% of them have muscle aches as the major symptom, with the COVID. And some of these symptoms do last even after the infection is completely cleared. They continue to have the myalgias. So that's one of the muscle symptom that we see. The other thing is CK, the muscle enzymes. As you all are aware by now, what is CK? Creatine kinase is the muscle enzyme, the breakdown product of your muscle. That is elevated in about 30.7% of patients in one study. And very high levels are seen, which we call as rhabdomyolysis, and also is seen in only about 0.2%. It's a small percentage. And actually, we published one paper, patient that had in 2020 that had this condition. And then there are other, like 4 cases was, Dr. Singh and his group have, presented 4 cases with rhabdomyolysis. And do we know the exact etiology? It could be the same etiology like any other muscle inflammation. These the viruses are actually causing inflammation in the muscles or directly causing damage to the muscles? We don't know that answer, but there is, these can cause rhabdomyolysis. The COVID can cause rhabdomyolysis. So that's something it is not common, as you can see, it's very rare, but it can happen. And what about myositis? Have we seen myositis? Again, we are learning a lot. We don't have a whole lot of information right now, but I could find like a few patients documented in the literature, and one of them by Dr. Bedon, he mentioned about a patient with MRI documentation of the myositis. I didn't see that he mentioned anything about like a biopsy being done, but the MRI showed inflammation on the muscle, and that's how they made the diagnosis of myositis. So this is people with COVID infection and having some muscle involvement. So can it happen? It can, like any other infections, but is the percentage any higher than other, normal in general population? I think it's a small percentage, but we are learning a lot, like as we go along. So there's a lot more to learn. And actually, there's a national database that is being looked at in patients with neuromuscular disease. Actually, that's an international database. They're collecting information of COVID-19 infection in patients with neuromuscular disease, and I'm sure we'll learn more. And so this is an important paper.
May I interrupt you for just a second?
Yeah, sure.
Is that a physician researcher database, or is that a patient reported?
It's actually physician database, but I'll find out and see if the patients can go directly and enter also. This is actually neuromuscular centers in different countries, and also be a part of it. We basically, if we know one of our patient had COVID-19, we collect information on that. And then, this is in the database, and we ask the permission before we do that. So that's something which I can find out if patients can go directly. I don't think it's that they can go right now, but I'm sure we'll have that open in future. We'll have more databases. And this is actually, that leads to this one. This is in, we were talking about Dr. Gupta, and their group had looked at, this is COVID-19 and myositis. Basically, they were looking at, it's a survey that they sent to patients with myositis, with idiopathic inflammatory myopathies, and they looked at what are the unique challenges for the patients during this pandemic. What did they face? What were the challenges that they faced? So there are a lot of like health-related problems were noted in 195 patients, and there were increase in the meds. They have to use more meds. There were some were hospitalized for disease-related complications. Again, these are not all, these patients, again, not all of them had COVID, or, this is just a survey sent to all the myositis patients. And during this pandemic, again, staying home or not being able to do a lot of things like, for example, physiotherapy. They also looked at physiotherapy. People with myositis, they need to be active. If they're not active, again, you lose your muscle strength if you're not using them. And so physiotherapy was disrupted in about 35% of the patients, and difficulty getting medications was reported in 1 out of 4 patients, and a difficulty contacting their specialist. So people had difficulty like reaching their doctors during this period, because obviously many people also had, again, the focus was more on COVID infections, and the doctors were also doing more remote, as you can see. And a number of patients supportive of remote consultation also increased. Many people wanted to just stay home and be on the Zoom rather than coming in person, because it was difficult, and they were worried that if they're immunosuppressed, are they more exposed to this infections? And have you changed the dose of glucocorticoids during this pandemic? There was a very small percentage of patients who actually increased, but majority of them did not, and some of them went off of that due to the, considering the risk with the steroids. And they also looked at, again, is it telephone, do they want to continue maintaining the medical care through telephone or audiovisual, or do they want to come in person? And it looks like many of the patients really, many of the myositis patients really wanted to do it tele even after this. And I'm thinking that's something which is going to be continuing for a long time. Again, the first visit is very difficult. I mean, for us in neuromuscular, we find it difficult for the first visit to diagnose someone over the phone or over the Zoom that they have like a muscle disease, or we like to see in person. And then, the follow-ups can be done can be done through Zoom or through tele. But I think the first visit always we prefer that they come in person. So this is the survey. We see that there is a significant number of people wanted to just do through tele or through audio visual, which is interesting. And I'm thinking that's something which is going to be continuing. And that's about the COVID and the muscle involvement. So going on, I'll be talking about COVID vaccination and in myositis also. Just first, I'll be giving you an update on like the COVID vaccination. And again, this is constantly evolving on a daily basis. You see new vaccinations coming up, and you also hear about like vaccinations from other countries and new variants of COVID virus. And so the information presented here is what I have from today. And we recommend, like, again, I'm going to be presenting some data, but again, I think it's always good to consult your doctor also, because your doctor knows you better than anyone else. So it's sometimes some of these may be catered to individual persons. So you have to make sure you talk to your doctor. So the latest information from CDC that you all are aware of is everyone over the age of 12 years can get the vaccination, and the CDC do recommend taking the vaccination at this point. And then, this is the latest one. So anyone about 12 years, prior to that, it was about 16, but now we have even about 12 to 16 has also been included. And Pfizer vaccination is what is recommended for 12 to 16-year-olds, and above 18, you can take the other two, and we'll talk about those as we go along. And the important thing, and we stress this, is widespread vaccination is critical for us to stop this pandemic. And that's, very important to know. So what is, again, there are a lot of vaccinations that we all are aware of in the recent years. I mean, in the last, I think in this 1 year, we learned a lot. And what is, the first vaccination that was approved in US was the mRNA vaccine, which was a Pfizer vaccine. So how is it different from the other vaccines? Again, the mRNA vaccine is a new type of vaccine which protects against infectious disease. So unlike the previous ones, which we used to use a weakened or inactivated germ into our body, and then allow that to create the antibodies against that. Instead of using that, what we are doing now is we are just teaching our cells to create a protein, and then the antibodies are formed against that protein. So how do we do that? We are basically introducing this RNA, and that goes into the cell, and it basically helps form this new protein, the spike protein, that's the Covet protein. And when the cell looks at that, the antibodies are formed against this, and that is what how the immunity is formed in people. So that's the mRNA vaccines, and these. So as you know, this is very important to know. It's not using a live virus, so so that's very important for us to know. So especially for people who are immunosuppression, and this was EUA, that's the emergency use application, was in December 11, 2020 for 16 years and older. This is the first mRNA vaccine that was approved, was Pfizer for EA use and EUA. And if you look at the data, this was, they looked, again, this is not a small number of patients, but you can see that they looked at participants without any evidence of prior SARS, the COVID virus infection. And as you can see, this is people who got the Pfizer vaccination, and this is the placebo group. And as you can see, the number is 18,000 people in each group. And you can see the numbers of patients who actually got the infection. And based on this, the efficacy of the vaccine was 95%. And they also looked at subgroups 16 to 64 and 65 and older. And it's not significantly different. It's 94 to 95% efficacy. And they also looked at participants with and without evidence of prior SARS-CoV infection. And again, you can see the significant difference between placebo and the Pfizer vaccination. And again, the efficacy is 94% in this group also. So based on this, basically they said that, this is a useful, I mean, this is how they allowed the EUA finally based on this data. And this is, I think, is better than any vaccination we know of, the efficacy, it's 95%. So in clinical studies, what they have noticed is the side effects included fatigue, headache, myalgias, arthralgias, chills. Again, some of this can also occur with the infection itself, but nausea, vomiting, and swelling in the arm where the vaccination is given. So these are some of the, and they're still collecting the safety data on all of these, all of this, and it is mandatory for the vaccination providers to present any serious adverse events, any multi-inflammatory syndromes, or any kind of adverse events. So, and we'll talk about what an adverse event is, but we have basically anything that we think is out of the norm, for any vaccination, I think has to be reported in that. So that was about the Pfizer. And the other mRNA vaccine that was approved is the Mrna Vaccine, as you all know. And again, this one, if you look at it, this was participants 18 years or older. So the other one was 16 and older. This one was 18 and older. And as you can see, the efficacy, again, looking at this in this was 94% efficacy. And when they divided them into under 18, from 18 to 65 and above 65, again, you can see the efficacy was more in patients from 18 to 65 than over 65 in this with Mrna vaccination. But overall, I mean, it's still good. It's still 86.4% in over 65 and 95.6% in under 65 age group. So it's still pretty good. And what is the side effects that they've noticed? Again, it's similar to Pfizer vaccination with fatigue, headache, myalgias, arthralgias, pain at the injection site, swelling at the injection site, and these can occur with that. And as you are all aware of the recent one, the Johnson & Johnson, which is the Janssen, which is one dose, the other two were 2 doses. And unlike that, unlike the Pfizer, BioNTech, and the Moderna vaccinations, which store the instructions, what this does is the Johnson & Johnson, again, it is a DNA component that you're using, and they added the gene for coronavirus spike protein to another virus. So they introduced that into the protein into another virus that is inactivated. So it's not, it doesn't cause infection. So that they took that virus and put the DNA into that, and that is what is injected into the patient, into a person. And this was, again, as a result of Johnson & Johnson, this one can be stored for up to 3 months. And so it is, unlike the other ones, which once you take them off, it can be put out only for a short period of time. This one can be stored for a longer time. And the Johnson & Johnson, again, this is just showing the mechanism of that. Like I mentioned, this is the spike protein, I mean, the SARS-CoV. We take the spike protein, and so basically what it's doing is the spike protein DNA is introduced into an adenovirus. That's the virus that it's like a vector. It's just carrying this gene into your body, and then it goes into the nucleus, and that helps create the spike proteins on the surface, and that causes an immune response, and that is how you get an immune response to that.
Dr. Pasnoor, so is that like an inactivated adenovirus?
So it is basically a virus that cannot cause any infection in you. Okay. So we're not talking about the SARS-CoV. We are talking about it's a different viral vector vaccine. So it's a vector. It's basically carrying that. It's an adenovirus. It's a virus, but it's modified so that it doesn't cause any infection, the adenovirus.
Wonderful. Thank you.
Sure. And this was the data that they presented with COVID-19. And the previous two vaccines were like, after 7 days, were looked at after 7 days of vaccination. And this is after 14 days of post-vaccination. You're seeing that the efficacy again of the vaccination was 73% in 60 years or older patients, and in 18 or older patients, 18 to 60, was 63.7%. So you can see it's a small, it's lower than the other one as far as efficacy. But then they looked at subgroups. What they did was they took they looked at the severe and critical cases between the placebo and the COVID-19, the placebo and the COVID-19 vaccine group patients. And what they found was that, it can prevent severe disease in about 85% of patients. And it's still, I think the efficacy is pretty good if you think about 84%, if you can keep them out of the hospital, that's what when we say severe or critical. And the adverse events, as you all know, initially, the adverse events, when they initially approved this, when they had the EUA for this, they the reported side effects were, mainly the local reactions and fatigue, myalgias, nausea. So these were, and some people had, they had one case of anaphylaxis, that is the severe allergic reaction, a reaction to the drug. But it was only one, which was in South Africa. But again, we continue to. I'll talk about the recent side effects that have been noticed with the Johnson and Johnson. So the vaccine adverse event reporting system, I think we all should be aware of this, and we should continue to monitor, to enter the information. It is available on the CDC website. What it is, we are still collecting the data for any adverse events for patients who receive the vaccination. And this is a very helpful tool for us to learn, because again, the trials were certain duration, but we are talking about more than, what is a long-term side effect? The only way we would know is if people start entering all the data, what they have, any kind of side effects, any kind of events that they have, and what is a serious side effect. When we say serious adverse event is something when you're admitted to the hospital, or life-threatening would be like serious adverse events. But other than that, anything that happens which is out of the norm would be like an adverse event that you would report to. Again, there is a group of people who will decide there whether this is related or unrelated to the vaccination. But I think it's important for us as, patients or as people, to report that. And there is that website that you go and report if you have any side effects from the medication. So as far as the Johnson & Johnson, once it was approved, and there was a pause, as you all know, because there was an increased risk of infection, of clotting. And there were 6 reported cases that in US that reported like a rare and severe type of blood clot. And actually, some of these were like venous clots in the brain. And so once that was noted, this vaccination was paused for some time. And if you look at, and then they looked at the data, and if you think about it, I know it's 6 cases. And if you think of the population, general population, we're not talking about people who got vaccination. This was before the vaccination. It's the instance of clotting in general population is 3 to 15 per million, and about 4.5 to 20 per 100 cases of COVID-19. So you can see that with people who have COVID-19, like infection, the viral infection itself, have a higher risk of having clots. And pregnancy, not having COVID or not have before the vaccination, just pregnancy itself is a risk for having clots, and the risk increases by 32 to 39 times. And for people who are taking oral contraceptives, like in young people, the risk is it's about 8 times to 132 times the general population. So you can see that there are a lot of other things that can cause increased clots. And when you look at the vaccination, the Johnson & Johnson vaccination, it was only 6 people out of the 6 million people who got, 60 million people who got this. And you can see that it's only 0.00009% of people who got this had this side effect. So if you look at it, this could happen even in general population, even without the vaccination. But so we don't know that answer. It could happen, but again, but since this happened right after giving a few weeks after the vaccination, usually we consider it as an adverse event, or if it happened within the first 6 weeks of the injection, so this, if it happened within that, we consider that. But if you think about it, if you look at all these numbers, it could happen even without the vaccination. Could it happen? It's possible. Again, we don't know that answer, but what they did was they basically released, they restarted, allowing that vaccination, but with the warning saying that, people under, they have noticed in Europe that people are under 50 and, women are more likely to have, and if you have any risk factors for clotting, like if you are on a oral contraceptive pill, or if you have any risk for clotting, then it's better not to take that and maybe consider other vaccinations. So that's basically, they released that because they saw that the benefit is more than the risk of getting a clot. So that's how. And so how do you sign up? Again, you all are probably familiar, and I'm hoping that most of you are already vaccinated. So I don't have to go over the details of this, but for people who have not been vaccinated, there are a lot of, access. Right now it's anyone over 12 it's a recommendation to take. Previously it was 16 and over, but now it's like anyone about 12, and you can reach out either to your county or to your provider, your doctor, or at KU Health Center, or any medical center close by. Right now, even if you're not a patient of KU, you can still get your vaccination, but I'm sure it's the same with other universities and other hospitals also, or even the county, health department also can give it. And even the pharmaceutical places like, CVS and Walgreens, you can get it anywhere right now. And you can go to I have the Kansas, but there's Missouri also. You can go to the CDC website, and there is a vaccination, how to get to find a location close to you. You can do that. And so the question is, what if I already have COVID infection? Do I wait for 90 days? This was the initial thought on, should we wait for 90 days? But, again, they've noticed that when they looked at the antibodies, it was variable. Some people had it early, some people had it late, so they relaxed that. If you don't have symptoms, you can basically get that. And when to get the vaccination, again, we say like it has as soon as possible. And if possible, just go ahead and get the vaccination. And this is just, I included a slide how you can get your vaccination at KU through my chart, but again, I know most of you are not in close to KU, but I'm sure there's a place that you can go close to your, in the wherever you're getting your care. And this is the CDC recommendation for fully vaccinated people. Again, they relaxed some of the rules, and now more, again, they talked about like, fully vaccinated people can resume some of their activities. Again, I think being immunosuppressed, it's always good to take all the precautions. And this is like fully vaccinated people can resume several activities is what the CDC now recommends with the new. And as you all know now, they even said that no masks, you don't need masks anymore. But I feel like it's going to be some time before everyone is vaccinated. So it's better to use your precautions and continue using social, as much as you can, wear your mask. And I think it's still going to be some time before we can say, but basically the fully vaccinated people, what you can do per CDC is you can resume your activities outside without wearing a mask, staying 6 feet apart, or except where required by federal, state, or local law. Like, for example, at KU, we still, in the health center, we still we still want everyone to wear the mask, but it could be vary from the local businesses. So just follow the rules of the local businesses. And you need to pay close attention to the situation at international destination. Like if you're traveling, I mean, make sure, as you all, I'm sure most of you know, like how bad it is in India now. And so you still have to use your precautions when you're going to places like that. You may have to, quarantine if you come back. And I mean, most of these are, I mean, from India, it's right now it's in lockdown, but, again, you have to still use your precautions when you're going to international destinations. And you do not need get to be tested before you leave United States, but you still need to show a negative test result or documentation of recovery from COVID if you before you board a flight to United States. And you still, this is from the CDC website today, actually, you still get tested 3 to 5 days after international travel. You do not need self-quarantine after arriving to United States. But if you're around someone who had COVID-19, it's better to be safe and try to stay indoors. So as far as COVID vaccination, so coming to this important topic, that is the COVID vaccine in people with myositis. Now that we understand what these various vaccinations are, COVID vaccination for people with myositis who are on immunosuppressant is generally a good idea, and that has been recommended even if you're on immunosuppression. And it is even imperative that with aspirin, if you have like bulbar, like if you have weakness of the mouth or difficulty swallowing, it's even more important that you get the vaccination as soon as possible. Even with the patients with interstitial lung disease, because as we know, many of the patients with myositis, I'm sure some of you probably have this, but what is called the interstitial lung disease, that is the lungs are affected. Even so, in these people, it's even more important because you're immunocompromised. It's even more important that you get your COVID vaccination. Again, you may ask the question, I mean, some of us may have the question that I'm immunocompromised. Will this work? Some protection is better than no protection at all. So that's something important to keep in mind, For concerns about comorbidity, like again, if you have GBS in the past or other severe allergies, I think you need to consult your doctor before you decide on getting the vaccination. But you also remember that getting the vaccination does not mean like, again, I have to say nothing is 100%. It is still 95% or 96%, based on which vaccination you're seeing, 80. So it's not 100%. So there's still a small risk. And, what are the major, this was with the Johnson & Johnson adverse events, like we talked about anaphylaxis. These are major adverse events would be like anaphylaxis. That is, if you have a severe reaction to the medication, to the vaccination. The other thing is thrombosis, that is the clotting risk. And, but these are also rare. And like I mentioned, it's only occurring about 7 per 1 million vaccinated women between 18 to 49 years old. And, again, and for women 50 years or older, it's even more rare. So what is the optimal timing of the COVID vaccine? This is important because I'm sure all of you are on some kind of immune therapy and you're wondering, when should I take this vaccination? So usually, I mean, with IVIG, normally we don't worry too much about the vaccination, but it'll be nice to take it 2 weeks before or 2 weeks after IVIG. If you are on every 4 weeks duration. But if you cannot make that vaccine straddle, then just take it in the midpoint of your IVIG schedule. Like for some people who are on every 2 weeks, you can wait for 2 weeks before and 2 weeks after. So you just take it in the middle, like, after 1 week of your, and but just get the vaccination. And should you consider sub-Q? Like, well, if you're on subcutaneous IVIG, that is, you're giving your injection by yourself, the infusion by yourself in your, tissues here on your abdomen or your leg. So this would reduce the contact with nurses. Again, I mean, this is for should you consider SCIG to reduce the contact with nurses? I mean, should you change to SCIG instead of IVIG? Again, that is something you don't have to go to that. I wouldn't say you have to, but that's something to avoid exposure during the COVID. That would be another option. For rituximab, when do you give? This is usually an important thing to remember, because rituximab suppresses all your B cells. That is the cells that the antibodies, the cells that form the antibodies. And if you're suppressing that, if you give a vaccination during that period, it may not produce the antibodies. So you may not have the immunity there. So that's why rituximab, usually it's given every 6 months for most of the people. Some people take it yearly, but it's better to have it around the midpoint. And I think some people even recommend doing it like a month before your next infusion. So it's basically anytime after 4 weeks time to develop immunity, like after the 2 shots you get, wait for at least 4 weeks, and it would be nice to do it like after 3 months would be better. 3 to 4 months would be better. And rituximab therapy is associated with other severe COVID-19. And again, during the pandemic, we tried to, if we had some patient who wanted rituximab, we were trying to avoid it during that pandemic and try to see if they can use other medications because of the risk of COVID infection during that period, because again, you don't have much immunity and these are suppressing all your B cells. And for plasma exchange, again, what that is like the dialysis, we don't use it as much in idiopathic with the myositis, but we use it in other autoimmune conditions. Again, we use it in the midpoint. And for other oral therapies, again, we don't have to worry. I would just say go ahead and take it anytime. That would be fine. And for steroids, if they can decrease the dose to the minimum that's possible and then take it, it would be better too. But again, we have to remember, again, or with any of these, we have to remember that it's a balance. We don't want you to throw you into a flare up either. If you're stable on some dose, we don't want to decrease the dose significantly that you go into a flare up during this pandemic. I mean, again, hospitalization, and I would say we are, close to getting better with the pandemic, which is really nice to see that there are less number of patients in the hospital now compared to when we were in the peak of the pandemic. But I still think we need to follow our precautions. But how did so when I took the vaccination, my personal experiences, like, how did I decide to get the vaccination? Again, being in this occupation, I think, and the comorbidities that I see with the patients, and the vaccine's efficacy, and I looked at the vaccine efficacy and side effects. I know we all worried about the newer technology, but I think this has all made me decide on getting, as soon as the vaccine was available, we just went right ahead to get the vaccination. Did I have some side effects? Yes, I did. But it was mainly just soreness of the arm and some headache, but it was only like one day, and maybe some in the second day, but it responded to some Tylenol and ibuprofen. I wouldn't say ibuprofen you should take right at the beginning, but Tylenol is fine, and I didn't miss any work. I was still working during that period. So that's my experience. But again, I had colleagues who were at home for 2 days after this, and and what are the take-home messages? Choices can be confusing, but all currently used available vaccines can be taken. They have greater efficacy and safety, and there's not many not significant concerns. And who should get it? Anyone about 12 now is eligible to get that vaccination. And be engaged in your health and reach out if you have any questions. And together we can win this war. And again, this is some older data, but I'm sure that we have more. 40.9% of the US population had received at least one dose, and 26, this was last month, but again, this is more than that now. And this was the various phases that each Missouri and Kansas have used. Right now, we are basically out on the 5th phase where everyone gets it, so we don't have to worry about the previous phases. They started off with long-term facility, the healthcare, and all that, but right now it's open to all people, and it's go. I'll just quickly touch on I just have 2 more slides, I think, and we'll just quickly go over this. Again, we talked about, how many people have been vaccinated and, millions of doses have been given, and typically takes about 2 weeks after vaccination to build up the immunity. And so you have to remember until 2 weeks after the second dose, you're not fully vaccinated. And some people are fully vaccinated against COVID. We still get sick because, like I said, it's not 100% effective. And we continue to monitor the side effects. This is just the second last, slide where I'm going to just discuss briefly on this. There are, I just wanted to touch this B cell and T cell immunity. B cell is where the antibodies are formed to a foreign object or foreign particle that gets into your body. It forms antibodies. That's the B cell immunity. Then there's a T cell immunity, which is like the cells directly attack the cells. And we think that some of the immunity is due to, after an infection, is due to the T cells. They create like a memory in them, and when the same virus gets into your body again, there's an immune response. It goes and attacks the cells. So we think it's a combination of B and T cells that might, and in fact, there is some research that's going on to study this, that this T cell response may be longer than the B cell response after an infection, like after COVID virus infection, we may have a B cell. And even people who had COVID SARS-CoV-1 infection may have some memory of that and may help in attacking this. Again, this is something which is being studied. And there has been an T cell detection emergency use authorization given by FDA to detect T cells in COVID patients who think that they may have had COVID in the past, but they didn't have testing at that time, and the antibodies came back negative because again, the antibodies can be variable. They can last either, we don't know if they last 3 months, if they last 1 month, or they last 2 days. We don't know that answer. And so that's why the sensitivity wasn't much and specificity with that. And so the this was another that was approved for the detection. So, well, thank you. I hope answered some of your questions through those slides, but I'm open for any questions now.
That was so great, Dr. Pasnoor. I knew you would come with it. And I feel like we just went to court and you laid out this amazing case so that we all know why it's so important to get vaccinated if our doctors will allow us to. So I really appreciate all of that information. And I'm specifically happy that you answered because, as you know, we're trying to get approval for me to start Rituxan. So I'm really happy that you answered about the spacing with Rituxan, because that was one of the questions I had, was since I know that I've formed antibodies, I'm on that study with Johns Hopkins, and they showed that I had over 200 or something, I don't remember, antibodies after the second vaccine. I'm glad to know that that spacing is helpful, because I was starting to worry that if we start Rituxan, that maybe I would lose the antibodies that I had already. So thank you for that explanation of the timing with that. And also the T cells and B cells. We've had a lot of people asking about the antibodies versus the T cells and B cells in our support video support meetings. So that was really helpful. Thank you. I think we have quite a few questions. I know that you answered many of the questions that had been submitted through your presentation. So brava on that. But I think Jerry is going to kick off the questions, and then we have a few others, if that's okay with you.
Sure.
Okay, thank you so much.
Thanks, Emily. And thank you, Dr. Pasnoor. That was a very compelling case. And I appreciate all the details that you helped us understand along the way, so that when you got to the points about the vaccine, we were all kind of on the same page. And I know that a lot of people are going to want to rewatch and look at those slides again. So we'll look forward to getting a copy of those that we can include with the recording, if that's okay with you.
Yeah, definitely. I'll share it.
Great, thank you. So like Emily said, you did answer a lot of the questions that had come in. There were some medication specific questions, and you did address that in your presentation. So we'll go to some of the topics that might need just a little bit more clarification. A question came in. Is there anything that we can do if the vaccine didn't work for us and we didn't develop antibodies?
Um,
Oh,
I mean, that's a good question.
I'm sharing your screen. I'm sorry. Can you stop your screen share?
Oh, sorry. Yeah,
It's okay. There we go.
sorry. Yeah,
Want to
yeah.
see your beautiful face. There we go.
Thank you. So, you said you mentioned that if the vaccine did not work because of the antibody, because you have been on a medication, or what was the why do we think the antibodies did not? I mean, the vaccination did not work.
I assume that they had the antibodies tested, and it didn't show any of the
So,
antibodies to the vaccine.
yeah, so that's a good question. But, like I mentioned before, is it only the antibodies? I mean, I know the levels are at this point, we don't know, they're not very sensitive. And so it's hard to say that you don't have any benefit from that. It's hard to say that. But again, is that something we are going to learn along the way, that if this does not work and we take another vaccination? We don't have those answers yet because, again, the trials have been just in patients. We got the 2 doses and we know that there is the forms, but we don't have any answers on that. Could it, I mean, I'm thinking in future, we might have like booster doses coming up, which we don't know yet. But is this, like I mentioned, that we don't know if it lasts for 1 year. I mean, based on the data, we know that they were 6 months in the trial and then they looked at 3 months follow-up after that. So about 9 months to a year is what data we have. We know that there is protection up till there, but beyond that, we don't know. So do these antibodies last like 2 months, 3 months, or more than that? Or is it going to last 1 year? We don't know that answer. And maybe we have a booster. So for someone who does not develop any antibodies, is that a choice? That might be something which we'll learn along the way, probably.
Great. Excellent. Thank you. Another question. Can I expect some COVID antibodies in my IV infusion at this time that might help support the antibodies in the vaccine? So from the blood donors that donate their plasma, are you finding that there's antibodies to COVID in that? Do you know yet?
Yeah. So, well, I don't know about the vaccination, but as you all know, like initially there was the plasma was given as a treatment for people who had COVID virus infections. That has been used as one of the treatments for severe patients and was approved, to be given. So, I mean, can the plasma from a patient who has infection help? That's possible, but again, from vaccination, it's hard to say at this point without having any data on that. So.
Great, thank you. So Jessica has personal experience with COVID, and she's going to share just a bit about that. Jessica, hi.
Hi, can you hear me?
Yes.
Okay, so I'll make it brief. I'm a COVID survivor. In January of this year, I had severe COVID. When I was admitted to the hospital, one lung was 100% infected, the other was 75%. I was breathing on about 25% of my lungs, and my blood oxygen was in the 70s. I was in the hospital for 18 days. I was put on a ventilator for 10. And once during that time, my heart stopped and they were able to bring me back. And by some very, very wonderful doctors and nurses and the grace of God, I survived COVID. And I did have extensive lung damage that I'm still dealing with. So I have interstitial markings on both lungs, and I'm on 3 liters of oxygen currently. But one of the silver linings, besides me obviously living, was that all of the massive amounts of steroids I was given while I was fighting for my life threw my polymyositis into remission. But I am now fully vaccinated, and I am a huge advocate for it, because trust me when I say that you don't want to fight what I fought, and your family doesn't want to go through what my family went through, not knowing if I was going to make it. So I just wanted to give an opportunity to share a real life-hand experience with COVID.
Thanks, Jessica. Jessica is also one of our volunteers, and we certainly appreciate her being willing to share that, open and honestly here publicly. Did you have anything that you wanted to comment on, Dr. Pasnoor?
Yeah, Jessica, thanks for sharing that. That is definitely a very touching story there. And I'm glad that everything went well in the end. And it's I know patients we see after the COVID, and it takes some people take a long time to recover. And I can feel what you're going through right now. And we hope everything gets better. I just had a question about your vaccination. Have you taken your vaccination, Jessica, after all this, or when did you take your vaccination? Or
yeah, I am treated through Stanford. That's where my immunology and rheumatology is, and they had me wait until the middle of April to get my first vaccine, and then I just got my second one almost. Actually, it was 2 weeks ago today. So I got Pfizer, and I am fully vaccinated. And ironically, I did have a reaction to both shots. Not horrible in any way, shape, or form, but I did react. And so, as my doctor said, that was a good sign.
Yeah. So yeah, I sorry to interrupt again. So one of you brought up an important thing. I think, when we say that someone has reactions to the vaccination, again, we are talking about, like, again, there should be some antibodies formed, and sometimes people who had an infection previously may have some antibodies, and when you're giving a vaccination, you just may have a little more reactions to that than other people. So we've seen that. Again, I don't think there's like a trial to say that, but out of experience and out of seeing patients having that, you may see a few more, few more adverse effects than you would see in people who did not have infection before. And you're right. Is it because you have a better immune response that you're responding to it, and you're noticing that? Again, we don't know that answer, but it's possible that you just are more, faster response, and that's causing some of that adverse effects, like, effects that you were talking about. Like, that's probably what your physician might have mentioned.
Great. Well, thank you. Such a wonderful discussion, and it's so great to hear, a real life story. So thank you for that again, Jessica and Dr. Pasnoor both. Before we move on to the last few questions, Manuel Lubines is our patient-centered research advisor, and I would like to, he has a question that I would like him, go ahead and unmute yourself there, Manuel, and welcome.
Yeah, welcome. Hello, everyone. This is Manuel Lubinus. My question has to do with the COVID. We had a very difficult time with COVID through last year. So I always trying to figure out what we learned from this. What was your learning from this experience? Is there any silver lining, either from the medical practice or from you personally, about after COVID and after the new normal after COVID? What do you think about that?
So that is a great question. I think, we all learn that we can't take anything for granted. First thing is, it's there's a lot to learn. I think we learn a lot along the way, and it's interesting to see how we came up with how the science has developed during this COVID infection. The newer vaccinations that were, I wouldn't say it's a fast track. I know some of us think that, and I have a lot of patients who say this is fast tracked, and that's why I don't want to take this vaccination. No, it's been there. It's been thought about for a long time, even when the initial, like, SARS-CoV-1, but they just didn't release at that time because they didn't need it. But right now, I think it's because we are seeing we've seen the development of new type of vaccinations, new technology, and again, that's one thing we learn. And like I said, infections, we can't take for granted. We are learning about the mechanism of how this is working, and we know how to, how to deal with it and the importance of vaccination. I think there's a lot we learn from this. And is it going to change a future? I think, again, I know we use social distancing and masks and everything, and it will take a long time to get us back to, where we were before. And, again, the things that came out of it is like, again, Zoom meetings and telehealth. And so there's a lot of changes that occurred, which probably are going to stay there. And, easy access for, I think it's also one way to connect all over the world. I mean, it's interesting, but during this COVID, I have, given lectures or talks to like people in different parts of the world, actually. So, which wouldn't have been possible if it didn't, if it wasn't the beginning of this pandemic. But, again, that's probably the good side of it. But again, we had a lot of deaths and we had a lot of, mortality, and like, again, those are, and we learned a lot of hygienic procedures. I think those won't change. So there's a lot to learn from this. And I think, as a community and as patients and as people who have gone through this, and, again, how much I think the medical community also like got together. And I mean, it's interesting, but one of our pulmonologists actually went to volunteer in New York when this pandemic was going on, because our hospital did not have as many cases as they were in New York at one point. And so he decided to go there and volunteer. I think that, that really shows that people care for others, which is really came out during this time period. I think, during this COVID pandemic, we learned a lot of those things along the way.
I think that's great. I think for myself, I learned that, for example, we get now to get antibody testing, we do go to participate in different things. So I hope those parts of like public health will continue to be there, because it's important to realize what are our deficiencies in public health, what can we do for the community. And I think those are important learnings, and how we can change the rules sometimes to teledocs and things like that. So hopefully that also has implications in clinical trials in the future, etc. So thank you.
Yeah, the clinical trials, I mean, definitely is one area that we have seen a rapid growth during this pandemic. People were trying to find new medications to save people and help people. I think, and it's continuing because again, we have the long haulers. I think most of us know that who have people who have undergone, like, had infection, have symptoms even after the infection is over. And just like any other virus infection, we are seeing a lot of patients. Actually, KU has started COVID clinics for patients who had COVID infections in the past and now have symptoms related and symptoms to diagnose. And we have that in different departments. So not everyone has like just myalgias, or some people have more lung related, some people have more, cardiac, or, so different. And so we have COVID clinics in every specialty, actually, which is, I think, you're right, Emmanuel. I think that's something that came out of this pandemic. We learned a lot, and we know like we need more, community and, like you said, public health measures. And yeah, definitely.
And the ways to disseminate and education and in ways that reach everybody. I think that's another thing that has been highlighted, is how do we reach those that are underserved, and how do we do that? And that's a conversation for another day. But Emily,
I think one of the things that I've enjoyed about the new way that we're living is that I haven't had a sinus infection or bronchitis or a cold, which I usually have multiple of every year, since we've implemented these masking strategies. And I don't think that I will completely ever give up masking. So I think that for immune suppressed people, at least, is a positive that came out of this horrible time. So So yeah, I just wanted to add that along with all of the other things that were wonderful that you said, and of course, mourning the people that we've lost along the way. So I think we have a couple of more questions. If Dr. Pasnoor, if you are able to stick around for a couple of more that I think, okay. So I know that you touched on the immune suppressants, but we do have one that's a little bit more specific that I don't think I heard you address specifically. I know that you said we don't really know about the antibodies, but if someone did not show antibodies from the vaccine, should they be talking to their doctor about getting vaccinated again, or should they hold off until we have more information?
I think it's holding off until we have more information, probably would be. It doesn't hurt to talk to them, but again, I think the doctor might give the same answer. We don't know right now if another vaccination would be useful or not. Just if we know for sure, like, you were suppressed at that time and you didn't know, get the antibodies formed, because antibodies are not tested in everyone. So we don't know how many people develop, what level of titer we develop. We don't know. We don't have that answer. So I don't think we have to think about it right now. But if something comes up in future, if we know more answers on that, then probably it makes sense.
So would you recommend then keeping the masking going for the time being then for immune suppressed people who are unsure?
Yeah, I think the masking, although I know the mask rules have gone right now, but I think if you're around unvaccinated people or even vaccinated people, I think it's still good to follow safe precautions for some time, because we also have to remember this new variants can occur for some time. We need to make sure hopefully, one of the things that we think is that these vaccinations may actually also help with other variants, but we don't have that answer. So if there are any new variants, like right now we are seeing in other countries, there's new variants which we don't know if this vaccination is going to work against them or not. And so I think it's always good to be safe for some time, at least when you're in crowded areas or crowded places where you would still mask. If you're outside and less number of people, that's okay, but I think we should still try to mask them.
Okay, great. Thank you. We have another question that says, I would like to know the risk of muscle enzyme level in COVID. My levels have been as high as 7,000 and I'm on methotrexate shots once a week.
So like I mentioned earlier, I think that's Teresa. Teresa, I don't know if you had the muscle enzymes from a COVID infection, or was it from your general myositis myositis that your levels were high. So if the levels were high because of your myositis, you need to continue being on the immunosuppressive medications to get that down. If it was due to the infection, again, did you develop like a myositis due to the infection? Like I talked before in my presentation, there were a few cases that they reported with myositis and they had to use immunosuppressive therapies to bring it down, just like you would do for a regular, like I mentioned, with the myositis, we don't have a definite answer why myositis occurs. When we think that there's some trigger, like a infection or something might have triggered an autoimmune process and caused, and the COVID could be the same thing. The trigger, it might be a trigger that's causing an autoimmune process and causing causing a myositis, like an inflammation of the muscles. The other thing is, if it is due to the infection, it should have improved by now, with the treatments or with the infection coming down. But if it's continuing, you think it's an autoimmune process being triggered by an inflammatory process post-infection. So I think you should continue with that.
Great. Thank you for that one. And then the final question that's in the Q&A, and Jerry may have a couple of more on his list, is, has Johns Hopkins released any findings on their antibody study? I have actually seen those, and we could possibly put that in the link or in the chat, but Dr. Pasnoor, do you have any information on that you'd like to talk about?
Yeah, I didn't look at all the details of that. Yeah, but I think, like you said, just sharing the data would be easier, I think.
Okay, great. Thank you. Jerry, did you have any more questions?
No, it looks like that's the end of our Q&A.
Okay. Well, Dr. Pasnoor, did you have any final thoughts before we close out? We really appreciate your time.
No, I think the only thing that I would say is get vaccinated. That's very important for all of us to be able to get back to our normal lives. I think is the more number of people are vaccinated, the better. And that's even if you are immunocompromised, and I think it's even more reason to be vaccinated. And just have to discuss with your physician on what the timing is. Again, there's many new medications that are out there, which again, I may not have touched all of them. So always discuss with your physician before you get your vaccination.
Okay. Well, thank you. We appreciate your time so much. And we hope that all of our guests enjoyed Dr. Pasnoor's webinar on myositis and COVID. Remember that with Myositis Awareness Month, we have so much more coming up. We have David Overby is going to be talking about hands-on physical therapy this week. He's also my practitioner. He's my physical therapist. So he's going to be talking about how he's learned about myositis in treating me. And we have a lot of other awareness activities and events coming up. Jerry, did you want to add anything?
No, I just want to kind of reiterate my thanks. It was a pleasure to meet you, Dr. Pasnoor. I certainly look forward to working more together, and just thank you for being such a believing in the patient-centered care approach that that it's not that part of it's not work for you. That's you're treating the whole patient, and that's always what we're looking for. So thank you for your time tonight.
Yeah, thank you for giving me the opportunity to talk to the group. Thank you.
Appreciate it. Have a great night, and good night to everyone else. Thank you, Emily, for moderating the session tonight. And check out understandingmyositis.org for more opportunities. And if you're able to make a donation, we're looking to raise up to $20,000 by the end of the month. And we're not halfway there yet, so we could use your support. Even $5 makes a difference. So thank you so much, everyone. We look forward to seeing you again. Good night.
Good night, everybody. Thank you.